Thanks, everyone. And just a quick note about our resources that we have. So we do have consultation services with Dr. Sereda and with Mark Barnes, who's also on the call today. We have a number of different meetings like this one, as well as interdisciplinary meetings. Check out our website for resources, events, archive of webinars and things like that. We also have an evidence brief that we keep up to date all the time. So if you're looking for evidence about safer supply, where things are at with the evidence base right now, please feel free to reach out to us. And if you need any help or support developing resources or putting together presentations, our team's also available to help out with all those sorts of things. And just a shout out to our next webinar, which is happening on December 5th. And that's the findings from an evaluation of the Safer Supply program at the Kitchener-Waterloo that program, the Kitchener-Waterloo program, which is a collaboration of a number of communities, organizations. So I'll put the chat or the link for that in the chat, as well as the link for our website. I'm on my own today. Normally my colleagues are like putting in all kinds of resources as I talk, but you have to wait for me to do that. I'm much slower on the uptake. Okay, so with that, welcome, and I'm going to pass it over to Sue Jane. And where's Angela is also here. There you are. So Sue Jane and Angela, I'll let you take it from here. Thank you.
Great, thanks, Rebecca. So just bear with me. I'm actually not used to putting presentations up on Zoom. I'm more familiar with Teams. Not quite sure where to, I guess I can share screen.
Do you have a share screen feature on there, or do I need to give you permission?
It does have a share screen feature.
Oh, okay.
I've maybe turn, sorry, give me a second, guys. All right. Can you see anything? Not yet.
Not yet.
Hold on. Let's see if that works.
There you go. Perfect.
Oh, great. That was easier than I thought. All right. Okay, we don't need the screensaver slide. We'll go right into it. So thank you, Rebecca. Okay, so hi and welcome. My name is Sue Jane Sang. I am one of the team leads for our pharmacy inspection units within the Controlled Substances Program in Health Canada. And today I'm going to be providing you all with a short presentation with a little on the federal regulations and pharmacist responsibilities in relation to them. I am joined online by my colleague, Angela Lena. She is a team lead for the pharmacy inspection units in Western region, and she will probably be helping me with the Q&A portion. So a quick disclaimer, the presentation does not constitute part of the Controlled Drugs and Substances Act or its regulations. And in the event of any inconsistency or conflict between the CDSA and its regulations, the CDSA and its regulations take precedence. So any information that's contained in this document is accurate as of the date of the presentation and is subject to change without notice in the future. Okay, moving on. So this is our outline for today. It's been modified a little bit from our normal presentation to kind of keep the focus on what we thought would be most relevant for you, which is a quick overview of the federal regulations of controlled substances. Then we're going to go straight into inventory control, loss or theft reporting, security, record keeping, and some additional resources that we thought would be useful for you. All right, so when it comes to controlled substances, Health Canada helps to protect Canadians by authorizing the legitimate use of controlled substances and precursor chemicals using a risk-based assessment and evaluation process, and by performing compliance and monitoring activities such as inspections to minimize the risk of diversion. And here we have a simplified version of our organizational structure. At the bottom, you can see highlighted. Can you see the cursor for my mouse? Okay, great. I might be moving it around a bit. So at the bottom, highlighted here, you can see pharmacy inspections. As you can see above, we're split into 3 different regions here, but we're all part of the Controlled Substances Program, which is housed within the Regulatory Operations and Enforcement Branch under Health Canada. The other group that I want to highlight to you is the Office of Controlled Substances up here on the right. They are based in Ottawa and part of the Controlled Substances and Cannabis Branch. They regulate distribution and sale of precursors and controlled substances. And whenever you submit a loss or theft report form, which we'll talk about later on in the presentation, that's where it goes to. It goes to them. So our 2 groups do have a lot of communication with each other. We do work together when needed, but I just wanted to highlight that they are linked but 2 separate groups. So when you communicate with us, you're not necessarily communicating with OCS and vice versa. Okay, so the CDSA provides a framework to control substances that can alter mental processes and that may produce harm to health and to society when they are diverted or problematically used. So you can see from this slide that our focus is on these 2 acts, the CDSA and the FDA and their associated regulations. I just wanted to highlight that we are working right now on a comprehensive controlled substances regulations. And when that comes in, it will supersede the 3 regulations that you see under the CDSA. So for the narcotic control regulations, benzodiazepines and other targeted substances regulations, and the precursor control regulations. All right, so let's go into regulated activities for pharmacists. There are specific provisions for pharmacists as well as licensed dealers and practitioners that exist within each set of regulations, and we will be covering some of them throughout this presentation. So we've got provide, sale, return, record, security, general obligations, and advertising. I'm not really going to talk about advertising, but I did want to note that in terms of advertising, basically it's not permitted for controlled substances. So any pharmacy signage and any web pages cannot specify the names of any controlled substances that you may have on your premises. The other thing that I wanted to mention is that in exceptional circumstances, OCS can issue exemptions to the requirements that we'll go over, and we'll look at have a very quick look at an exemption in the next slide. Okay, so when we have regulations, we can, in certain circumstances, have exemptions. Section 56 of the CDSA provides for this. There's a couple examples here of these exemptions, but the main one of interest is likely the class exemption for patients, practitioners, and pharmacists prescribing and providing controlled substances in Canada. This exemption came into effect early on during the pandemic, and it allows for cross-province transfers of prescriptions and extending of existing prescriptions. If you want more information on that, we do have a link at the end of the presentation that goes into other Section 56 exemptions. Oops. Okay, so moving on to pharmacist obligations. So it seems a little out of place here because it actually refers to the obligations in relation to an inspection. But I wanted to leave this in because everything that we're covering in this presentation are things that can be looked at during an inspection. So we will go straight into inventory control now. Okay, inventory control. You should have a perpetual or live inventory for your active or viable inventory, for your unserviceable or expired stock, and if you do compounding for your active pharmaceutical ingredients. The inventory should be tracked either manually or using pharmacy software. I have once in a blue moon seen it tracked by paper manually, but that's really difficult. So in my experience, I have been to pharmacies as an inspector where they've told me that they don't have perpetual inventory, and it's okay because they've heard that they aren't reliable and that the stock numbers can be manipulated. And that's true. Nothing is foolproof, but it is a very useful tool to have, and it can aid you in quickly identifying any discrepancies in your inventory, especially if you're dealing with larger stock volumes. So some of the things that you can do to make that perpetual inventory more robust is set up user restrictions in your software to restrict who can make those manual adjustments to your inventory numbers, and also ensuring that there are prompts to require an explanation whenever an adjustment is made. But probably the number one thing that you can do to keep up your perpetual inventory is just ensuring that when you have orders and purchases, that you update those in a timely manner in your system. So this can help you keep up and make it easier to do regular inventory counts, which in turn will help you with detection of diversion. The next thing is reconciliation. This process can help to validate your perpetual inventory record and assess the overall inventory control. So if you're not that familiar with reconciliation, I will talk about that again in much more detail in a few slides. But we'll go back to physical counts first. So your provincial regulatory body, it may require a different count frequency than we do. Generally, we recommend that you follow whichever is the stricter requirement. And apart from that, there's a couple examples here of times when you should have a count conducted. I won't go through each one, but with respect to the second bullet, when security is compromised, a couple examples of that would be armed robberies, break-in entries, if there's a suspected or detected internal theft or drug diversion, and if there's a discovery of faulty security measures, like say there was an unlocked or unsecured door or window. Okay, so next, how do you conduct the counts? When you do your physical counts, please do not rely solely on an automated machine or a robot. If you do an initial count with one of these, then ensure that a manual count is done after by a trusted individual in the pharmacy to verify the physical stock. When you do your counts, if you have differences between your physical count and your theoretical on hand, you will need to do an investigation and a reconciliation. If any of these differences are a loss or a shortage, and an explanation cannot be found, then you have to submit a loss or theft report within 10 days of discovery. And finally, with all of this, remember that the records of these counts, as well as the investigations that you do, have to be documented and they should be maintained on site for at least 2 years. So the last point about manual counts and reconciliations. So a manual count does not equal a reconciliation. A comparison of your physical on hand versus your theoretical on hand will not necessarily always reveal discrepancies, especially if there are no controls on the manual adjustments, which is why we also do reconciliation. Okay, so let's move on to those reconciliations. The expectation is that pharmacies are regularly performing inventory control tasks. When we do an inspection, we go on site and assess how the tasks are working. We may highlight areas for improvement where necessary. So maybe to give you a bit of a head start, when you do a reconciliation, we'll just run through a quick version of this. So when you start with your reconciliation, you have a starting inventory. So that means you should have had previous counts. You want to make note of the date of that previous count, when it was conducted, add the purchases between the time of that count and the date that you're doing the reconciliation. We'll just say that's the present date. So add those two together, then you'll deduct the sales within that same time frame, and that would give you your theoretical calculated number. And from this, then you have the calculated theoretical to compare against your physical count. And when you look at that, any discrepancies that you have from there will be investigated and again, document those investigations. So a couple things to remember when you're doing your reconciliation is that pharmacy software can provide the calculated or expected on hand, but sometimes those can be prone to error. It could be because of miscommunications between the supplier and pharmacy software. It could be from misprocessing, such as part fills, or if you have canceled prescriptions, things like that. Doing a reconciliation can help you to root out the cause of that discrepancy. And also, when you look at your manual adjustments, you should be verifying that against other records, such as your destruction records or a spill log if you are doing methadone. So to provide a little more clarity, we just have a quick example of a reconciliation calculation. Say, for example, we'll take like dilaudid 8 milligram. You have a starting inventory count that you did on January 2nd. You had 250 tablets of dilaudid. Between the January 2nd date and your current date, you have your purchases. So you purchased 800 tablets. So then you add these two together, you get 1,050. And then you look at your sales. So these are your dispensed prescriptions. So you add up the prescription sales from January 2nd to the present date. You dispense 750 tablets, minus that from your 1,050. This is your so this is your stock balance. So theoretically, you should have 300 tablets in stock. Okay, next, then you'll look at the physical count that you did on the date of your reconciliation. Say you did your physical count and you had 200 tablets in stock. So then you're going to compare it against the 300 that you calculated. When you do this, the 200 minus 300, you have 100, you're out 100 tablets. So you have a difference. The next thing you have to do is like, do you have records to account for that difference? Were there quantities that were expired, destroyed? Was there a part fill, a owing, or maybe canceled prescriptions, things like that? This will lead you to do an internal investigation. So here are a couple examples of things that you can look at during your internal investigation. I won't read through every single one, but you should make sure that when you investigate, you should look at positive discrepancies as well. A positive discrepancy may seem less concerning than the negative one, but you don't want to end up adjusting your inventory based on a false positive. So because it can affect your ability in the future to detect any negative discrepancies. So before you make any adjustments to your inventory, always make sure that you're investigating both negative and positive discrepancies. And of course, make sure that you document everything and keep the records on site for 2 years. Okay, so once you've done the investigation, we're going to look at the result. If the discrepancy was explained, then you'll adjust your perpetual inventory and remember to document the rationale for that adjustment. If your investigation did not result in any definitive explanation for a loss, then you have to submit a loss or theft report form to the Office of Controlled Substances within 10 days of discovery. And then, again, adjust your perpetual inventory. You will note that it is important to adjust your perpetual inventory regardless of the outcome of your investigation, so that you do not keep carrying forward that same discrepancy for any future accounts and reconciliations. All right. So loss or theft reports. This is an example of the PDF fillable form. So pharmacists have to retain a copy of this form for a period of 2 years, and it should be made available upon request if you happen to have an inspection. What is reportable in the loss or theft report form? So this would include things like theft, which includes dispensed forgeries, any suspected diversion, if there is no reasonable explanation for your loss, and yeah, anytime there's no explanation for the loss, it should be reported. Things that are not reportable, you wouldn't report the overages. You wouldn't report discrepancies that are reconciled with explanation and have supporting documentation. You wouldn't report documented dispensing errors, like if it's the wrong patient or the wrong quantity, as long as you know what happened. You wouldn't report expiries or destructions. And if you do happen to witness a spill or tablets being crushed or breakage, those are all witnessed and there's an explanation for them. You do not need to report that loss. Okay, so if you are doing an internal investigation, and it can take a while, and you're getting close to like that 10-day reporting deadline, we always recommend that you make sure you submit the report before you pass that 10 day, within 10 days of discovery deadline. And you can continue the investigation after that. We do allow for you to submit amendments afterwards to your report. So, I mean, if you finish your investigation and you're able to figure out that like you don't have 35 lost tablets, they were in blisters or something like that, you can submit an amendment. And that can be for the full amount, or if you find a portion of amount, you could submit for either. All right. So we have two different ways that you can submit. The first one I mentioned is using the PDF fillable form, and you can send it via email. The other way is through our Health Canada e-services portal. This is probably the most efficient way to submit your loss or theft report. It's kind of the preferred way from OCS. Some of the advantages of submitting through the portal are being able to view a consolidated list of all of your submitted reports, even if it's across multiple sites, like if you work at multiple different pharmacies. But just remember that only you can see the reports that you're submitting. Other pharmacists in different pharmacies won't be able to. You can also very easily amend your submitted reports once they have been accepted by Health Canada. And there's a couple other highlighted advantages here. The one thing I do want to note, though, is that even if you submit it through the portal, you must save a copy of your report, either in an electronic or a printed hard copy on site at the pharmacy, because the account for the portal is connected to the pharmacist. When you go to sign up, and we do have instructions for that, it's quite user-friendly. You will apply for a GC key that is specific to the pharmacist. So whichever pharmacy that you send a loss or theft report from, only you will have access to. So it's always a good idea to keep copies of those reports on site for that specific pharmacy. And also, if you leave the pharmacy, then that pharmacy will no longer have access to any of the loss or theft reports that you've submitted for them. Oh, and one last thing to note too is that pharmacy assistants, students, and registered techs can also create an account, but they can't submit the loss or theft report. So they can create a report and submit a draft to you, and then the pharmacist will have final approval and submit the report. And again, we will have links to all of these. All right, so let's go on to security. With respect to security, federally, we don't have any specific requirements, such as a prescribed list of mandatory security elements. But what we do have in the federal regulations is like a more broad spectrum requirement. This is because there are different provincial requirements in how controlled substances are stored. So Health Canada doesn't require that they be stored in any kind of specific way, such as it must be stored in a safe versus being dispersed on the shelf, or having to keep similar types of drugs together versus separating them out. Having said that, it is the pharmacist's responsibility to ensure that the methods that they use to manage their controlled substances stock allows for a high level of security. And I can tell you that during an inspection, most of our observations, aside from inventory control, comes from security measures. So here are some measures that help to ensure high levels of physical security. Having an alarm and surveillance system, so that's camera systems, motion detection, things like that. Installing physical barriers such as locks, a safe, metal bars on doors and windows if needed. I have seen some pharmacies with that. I know not all of them have them. Restricting access to the dispensary. You should really only have pharmacy staff in the back of your dispensary. And finally, maybe the most important is not sharing your narcotic code. We see this as inspectors, we see it all the time. Every time we go to a pharmacy, please do not share your narcotic code. Your narcotic code is connected to you and to your registration number, and whatever it is used for, whoever uses it, it's connected to you, and you're the person that will be held responsible if your code is used for ordering and if there's diversion. Other security measures, things that to keep in mind are time delay safes. So I know not all provinces have mandated time delay safes. I believe it's basically Western Canada and Ontario that has done that. So BC, Alberta, Saskatchewan, Manitoba, and Ontario all have made it mandatory in their provinces to have time delay safes. I'm pretty sure it's from Quebec onwards. So Quebec and the Atlantic provinces haven't made it mandatory yet. But it's definitely something to consider, especially if you're dealing with high volumes of stock. Something else that's quite important, but maybe the most difficult thing to do, is controlling the amount of stock that you have and keeping a reasonable inventory level. You should try not to have an unnecessarily large stock on site, because the more you have, the more there is to safeguard. There's more to count. It's harder to keep track of them. And in the event of a robbery or a break and entry, then you have a lot more stock to lose. And it can also make you a target if it's known that there's stockpiles in the pharmacy. So keeping a lower stock level also makes it easier to detect small losses. When you have less stock, it makes any missing amount much more noticeable, and that can in turn help to deter potential like internal theft or pilferage. Okay, moving on to records. As mentioned, federally, we require records to be maintained on site for a minimum of 2 years. However, your provincial regulations may require a longer period. So these records should be maintained in an auditable manner. And what does that mean? It means that they should be easily retrievable and legible and in relatively good order. So best practice is probably to keep it in a folder or a binder altogether, not scattered throughout your pharmacy. I'm not saying any of you do this, but we've definitely been to sites where you've got different sets of inventory counts and things from one end of the pharmacy all the way to the other. And the stress level of the poor pharmacist when we come in to do for an inspection is really high in cases like that. So definitely try to keep those in order. If you are going the paperless route or the less paper route, that's great. We love seeing that. Just make sure that you meet the requirements. And practically speaking, that means that whatever we could normally find in paper, you should be able to bring up electronically. And that includes being able to select for and produce a separate narcotic file if needed. And if you're going electronic, also keep in mind that you should have a backup copy, which is accessible to you at any time, which means that it's not housed in a third-party platform. A good example of this is purchase records. Everyone has an account with their supplier and they can access them, they can make orders, they can sign off on their invoices on the supplier's website. But if it's only housed there, then what happens if the supplier site goes down or if there's hacking or something like that? That means that all of your records that are housed there, you no longer have access to. So it's always best practice to keep a copy, whether it's electronic or printed out, in the pharmacy accessible to you. Okay, home stretch. This is just a quick table of the different kinds of records that you should have in your pharmacy. We've touched on most, but not all of them today. We've got purchases and receiving, dispensing, special prescription file, emergency transactions we didn't really touch on. Let's see. Next, destruction. There's a whole this is a whole area we weren't able to touch on. If you guys have questions in the Q&A, Angela and I will be happy to answer any of your questions. Then we have also got return authorization, and I think we've told you everything we can about loss or theft. One last note, moving on to opioid labeling. Please remember that any opioid prescriptions that are filled need to have this warning label on the immediate packaging, and it should always be accompanied by this handout. Both are available on our website, and we have links provided for them as well. It has happened more often than I expected that I've gone into a pharmacy that they'll forget to put the warning sticker on things like blister packs. They also will not have the right color. They'll be missing a little caution sign there. What you see here is exactly how the label should appear to avoid any kind of observation for inspections. Okay, finally, this is just an example of our information package that we provide when we go on inspections. We used to have paper copies that we would hand out, but we generally send them by email after the inspection now. It gives you a little bit more information on pharmacy inspections and also includes some useful links to relevant Health Canada web pages. I actually do have these provided for you in the next couple of slides. So we do have a consolidated pharmacy splash page now on the Health Canada website. It includes links like to record keeping requirements, stuff like that. And one thing I wanted to highlight is that the recommended guidance for community pharmacists that used to be located on the NAPRA website is now located on the Health Canada website. Here are some other useful links. I think we can make a copy of this presentation available too if you guys needed access to the links. I can coordinate with you after, Rebecca, to send something like that out. All right, and next are contact information. Well, as I mentioned before, we're divided into 3 different regions. My colleague Tim wasn't able to join us there, but he is a team lead from Eastern region, and I'm the lead for Central, and Angela is from Western. Any of these emails you can use to contact us. We check these emails regularly, and if you have questions, we'll respond to them. Like, we're always checking these emails. All right. So that concludes the presentation. It would be really helpful if you could take the time to maybe fill out a quick survey for us. The links are provided and there's a QR code as well. It only takes like a maximum of 5 minutes. The survey helps us to improve and update the content of our presentations for all of you. And please feel free to suggest any topics that you would like to know more about or hear about that maybe weren't covered here today. So thank you very much.
Great, thanks, Sue Jane. Any questions for Sue Jane?
How do I end this?
I had a question,
Sure.
if I may.
Yep.
Yeah, I was just wondering, you had suggested to not carry too much supply on hand. I was just wondering like how many weeks supply can you recommend? And I guess the other variable is the shortages and whatnot that we see in this area, that sometimes can be a concern where we run out of a product. So yeah.
Right. I'm sorry, Ahmed, I don't really know which area you're in. I can say I'm in Toronto.
Hmm.
And we
I'm in
definitely have,
Vancouver.
you're in Vancouver? Okay. I mean, probably similar situation. We do run into shortage situations here as well. Um, that is a difficult question to answer because we have I know everyone always wants to make sure that they have everything in stock, but especially if you're dealing with safer supply, that can quickly that can balloon into very large volumes. I would say actually a couple of weeks is probably quite a large amount already to have in stock in the pharmacy, depending on the
Hmm.
numbers that you have.
Hmm.
You want to look at like safeguards that you have in the pharmacy too, right? Like, is it able to be contained in your safe? Like, can you keep everything
Hmm.
securely? It's really up to the pharmacy, right? Like what security measures that you have can have there, and
Hmm.
what you're able to control in your inventory. Like if you're going to have a huge stock, maybe you want to consider things like more documentation, like making sure you do more counts, like cycle it or something like that.
Hmm.
Angela, do you have anything to add?
No, that's about it. I mean, the biggest thing is about your supplier and making sure, you know your supplier, you know your customers. So we know delivery can happen the next day. So just trying to stay a step ahead on your delivery without stockpiling too much.
Mhm.
Hmm.
And
Yeah.
if you're able to like rationalize why you have the supply you have, demonstrating that you're able to provide the appropriate controls and all of that, is that like sort of the key piece to addressing, I guess, any potential concerns, like if there was an inspection or something? Is that, if there's no like set amount of weeks or
Right.
days or whatever?
Yeah, I mean, the main thing is being able to keep secure what you have. Like we're not going to go in and say, well, you cannot have this much, you should be limited to like such and such an amount or anything. What we're looking for is to ensure that you've got good security measures around it, like you're doing your due diligence to safeguard what you have in stock. I mean, our recommendation is always going to be to keep as minimal stock as you can while being able to function as you do as a pharmacy.
Hmm. Yeah, it's just I find when there's new molecules that get more, I guess, prescribed. Like a couple years ago, Cadian was being prescribed more and more, and there was a shortage that was almost a month or more at times, and so having to switch people to MS Salon and other options can destabilize folks. So I
Right.
guess, and then the wholesaler ran out, and we do try to communicate with our wholesaler and tell them projections, especially if it's a newer molecule, of what we're thinking of, what see we're going to be having prescribed. And so that helps for sure. But yeah, I was just curious. So I guess the answer is like only a day's worth or a week's worth kind of a thing. So quite a smaller amount as much as possible.
For to us, the smaller amounts, the better. As
Yeah.
as Angela mentioned, though, like you guys order regularly, you're familiar with your suppliers and with their schedules and things, right? So, I mean, you would try to order appropriately, but knowing maybe you have a little bit in stock to cover if like you missed one day, things like that. I mean, I understand there's a pharmacist, there's several things that you want to keep in mind, right? You don't want to end up not having stock for your patients.
Yeah, like if there's an injectable hydromorphone patient and they're on 250 milligrams twice a day. I just don't want to run out of that. I would feel terrible because then you're basically sending them directly back to the illicit market,
Right.
which they could, die. So I guess that's the consideration there. But okay, thank you.
Yep. Bottom line is inventory control and security, right? So the more you have, the more you need to be diligent. The tighter you are, the less likely it is somebody's going to try and take it. The big one is internally, like we can't stop armed robberies, we can't stop B&Es, but internal pilferage is an issue in some pharmacies in some areas, and even just walk-in people stealing. So again, time delay safes are good for that. It deters that temptation to say, this guy's got a lot of Cadian in stock. I can steal lots from one place. So you got to realize that you could be a target, right? Like that's something a lot of pharmacists are they're usually amazing people who are very trusting and really want to help people. And that is a good thing. But at the same time, they don't always see the dark side of the business that they're in and understand that there are risks. And these are the things you need to do to try and mitigate those risks and make sure that what you're buying is going to the right people.
Yeah.
And I'll just note that I don't know if Sujane saw it. There was a clarification on the opioid sticker in the chat. That is true. If it is for the opioid treatment, you do not have to put the sticker on the prescription. But if it's a regular prescription for those drugs, then yes, they do need the sticker applied.
That's good. I wondered when I saw that sticker. I thought,
yeah, no, it is understood and it is clarified in the documentation on the link to that website that for certain types of treatment, we get a lot of resistance. Pharmacists say, well, the patients don't want it. They don't want the sticker. They don't want that. But our thing is you have to have it and you have to offer it. We can't make the patient take the piece of paper, but people need to be made aware that the prescription they've received, especially when it's a new one, that they understand what the risks are with this type of medication.
there's a question from Jared. Does that apply to safer alternative prescribing for OUD, like hydromorphone tablets? I would think so.
Yeah. I mean, basically, if it's to do with any kind of opioid therapy situation, be it safe supply or anything of that sort, then it doesn't have to have the sticker because you're dealing with people who know. They've already crossed that line into the problems of those kind of medications, and so they don't need that kind of sticker and handout. It's more for, not every pharmacy is uniquely just doing safer supply. They likely have the odd patient that will still come in and get other prescriptions for other reasons.
Great. Okay, I'm going to stop the recording. Where's my recording? Oh, there it is.